everyone to Journal Club, and a special welcome to our new PGY4 residents and our new fellows. I see some of our new fellows online as well. Welcome to you as well. Our co-chief residents will lead off the academic cycle and, as always, set the standard for our program. First, the land acknowledgements. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. First up today, Dr. Amanda Chen, PGY5, to present on the association between cataract extraction and development of dementia. Amanda, please feel free to unmute, and your slides are shared. Go ahead.
Good morning. Hi, everyone. My name is Amanda, and I'm a PGY5 in geriatric medicine. I will be presenting on a recent important cohort study that was published back in December 2021 from JAMA Internal Medicine. And the title is Association Between Cataract Extraction and Development of Dementia. I have no conflict of interest to disclose. In terms of the objectives today, I would like to summarize the study design and results, to critically appraise the study's methodology as well as the results, and to discuss the potential implications for clinical practice. So this is the study again. Some brief background. As we all know, dementia is a worldwide health condition that affects up to 50 million people worldwide. The recent Lancet Commission report highlights the importance to reduce risk or potentially delay dementia. And by addressing sensory impairment, that may be a potentially modifiable risk factor for dementia. In terms of the study objectives, the specific question that the study hopes to answer is whether cataract extraction is associated with reduced risk of developing dementia. The population is 65 years of age or older and has to be dementia-free at the time of enrollment to the ACT study, Adult Changes in Thought. I'll talk about that a little bit more in the next slide. The exposure is first cataract extraction and compared to those who did not undergo cataract surgery. And the primary outcome is all-cause dementia, as well as the secondary outcome is probable or possible Alzheimer's disease dementia. Of note, all-cause dementia here is specifically defined by the Diagnostic and Statistical Manual of Mental Disorders. For the study protocol, the ACT study is an ongoing population-based prospective cohort study of older adults that began recruitment in 1994 to 1996. The participants were randomly selected and recruited from Kaiser Permanente Washington membership, and they are followed until the development of dementia. Bit more information about Kaiser Permanente Washington. It is an American integrated healthcare model for different insurance plans. There's different health plans for individuals, families, through the employer, as well as they also provide coverage under Medicaid and Medicare. In terms of the inclusion and exclusion criteria, So inclusion criteria: age more than or equal to 65 years of age, dementia-free at the time of enrollment. They did not exclude participants who have concurrent other ophthalmic diseases. And for secondary analyses, they also included participants with diagnoses of glaucoma as well as their surgical records. Once they are enrolled, at the time of enrollment and during biannual visits, they receive standardized cognitive screening tests, brief physicals, medical history, and risk factor assessments. The exclusion criteria is the individuals who have had prior cataract surgery before ACT study enrollment, as well as if they do not have apoligenotype data available. Here is the brief study design. So 5,546 participants were enrolled in ACT. Of those, about 1,000 were excluded who did not have genotype data. So about 4,500 participants were continued. And then of those 3,000, approximately 3,000 participants were diagnosed with cataract before dementia onset. Of those subdivided, about 1,500 were incident cataracts and about 1,400 were prevalent cataracts. And then of that group again, 1,300 underwent surgery and about 1,600 did not go through surgery. Incident cases are when participants change from a no cataract status to cataract status after enrollment in ACT. Prevalent cases are individuals who already live with cataract diagnoses prior to this. Statistical analysis. I'll talk about this a little bit more in the slides afterwards as well, but they used Cox proportional hazards regression models and used age as the time axis. There's 3 different models. Model 1, where multiple sensitivity analyses were performed, which I'll talk about a bit more later. Model 2, they used a marginal structural approach, and in order to address the potential healthy patient bias. In model 3, they repeated the primary model, but this time repeated with glaucoma surgery, which does not improve vision as the exposure among people living with glaucoma. Looking now at the results. So these are the baseline characteristics of the participants in the study. Just to note, on the first red box, the age at first cataract diagnosis, the average overall is 74 years. And in terms of self-reported data, the majority of participants are self-reported white race, so 91%. And just looking at average years of education, they've all had at least completion of high school degree, so 14 years, so 2 years after that. And 26% or so individuals had ApoE alleles. I just wanted to note something kind of interesting. These are self-reported data where they said if they had any ADL impairment, so about 22% of participants have self-reported impairment. It is not clear in the supplemental data what is the underlying cause of their ADL impairment, whether it is specifically due to vision or something else. Looking at the primary outcome, so in model 1, the first half of the page, the study conducted multiple sensitivity analyses to allow for the determination of the robustness of an assessment by examining whether the extent of the results are affected by the changes in other variables. So they omitted the first kind of 1994 to 1996 cohort. They excluded surgery 2 years prior to censoring. Looking at incident cases, adjusted for recent versus long-term threshold, adjusted for recent versus long-term threshold to 10-year window. In terms of model 2, so the marginal structural approach uses weights to create what is called a pseudo population. in which there is no healthy patient bias, and performed analyses in this pseudo population of the relationship between cataract surgery and dementia risk. So essentially, the weights for the pseudo population emphasize for people who would have been less likely to receive surgery but did anyways, and for people who were likely to receive surgery but did not. And then lastly, in model 3, they conducted analyses on glaucoma and glaucoma surgery as the exposure. And as you can see here, glaucoma surgery, which did not improve vision, did not have any association with Alzheimer's or dementia risk, whereas the above has, looking at the hazard ratio. In terms of when considering the relative associations of cataract extraction, so looking at these different variables, years since cataract surgery, less than 5 years, more than 5 years, additional education, white race, past or current smoker, alleles, and gender. So looking at all of these, only covariate that was more protective than cataract surgery is if the participants did not have the allele. Moving on to critical appraisal. So are the results of the study valid? Did the study address a clearly focused issue? I believe so. So it has a very focused question looking at whether cataract extraction reduces risk of dementia. Was the cohort recruited in an acceptable way? Mostly. So the ACT study is an ongoing population study, which is randomly selected and recruited from the Kaiser Permanente Washington membership. The only thing I would add is that it does not include individuals who do not have a valid healthcare plan. Was the exposure accurately measured to minimize bias? I think so, because it has really put in a lot of work to adjust for multiple sensitivity analyses and try to use the marginal structural models to address the healthy patient bias. Have the authors identified all important confounding factors, and have they taken them into account in the design or analyses? I would say the majority, yes, just listing out what they adjusted for in terms of potential confounders. I think it would be helpful to just adjust for other important risk factors for dementia, such as alcohol use. Was the follow-up of subjects complete enough, and was it long enough? Yes, they really received biannual visits with kind of standardized cognitive screening tests, physicals, medical history, and risk assessment, and they were all followed up until the development of dementia. Are the results important? Can it be applied to the local population? Yes, I would say mostly. Despite being mostly more highly educated and white race, they did adjust for those in the sensitivity analyses as well. And does it fit with other available evidence? Mostly. Vision impairment is an important dementia risk. There has been some conflicting results about the association between cataract extraction and cognitive impairment. But looking at some of the other studies, the majority of them used either a telephone questionnaire or a dementia risk score, and not necessarily as full of a clear diagnostic criteria for dementia as in this study. Looking at the limitations, so cataract diagnoses and surgery were only based on diagnosis and procedure codes from the medical records. So there was no available clinical data such as cataract severity or visual acuity, as well as there could be a potential possibility for coding errors. The study population, as I said, is mostly white race and higher level of education. They adjusted for most potential confounders, but not alcohol use. And the study evaluates only the participants' first cataract surgery and not subsequent. In terms of conclusions, so cataract extraction is strongly associated with a lower risk of developing dementia among adults 65 years or older, and the effects are seen to be lasting for more than 10 years. So I think that's important for our clinical practice down the road, as we may already know, but just having that assessment and referring them for potential cataract surgery if appropriate. Thank you very much. That's the end of my presentation.
Thank you very much, Amanda, for the excellent presentation, clear slides, and great articulation. Barry has a comment in the chat box, which I think you addressed after the comment was made. He states, is there any comparative data on visual acuity measurements? And you mentioned that with other available data. Perhaps you'd like to expand further?
So they used specifically only diagnostic codes and procedure codes. They do not have the specific clinical data of each participant in terms of the severity of the cataracts and visual acuity.
Thank you, Barry. I see your hand is up as well.
Yeah, I'm at the age where many of my friends and people I know have had cataract extractions, and the reasons vary. It's not always visual acuity. For example, if you're an artist, I have one friend who's an artist, wanted to get them done early because her color appreciation was impaired. Others who want to drive at night, even if their corrected visual acuity is 20 out of 20. So you can imagine that those are a slightly different group who push for early cataract extraction. So this is interesting, and I think there's more than enough reason to want your cataracts removed if they're causing trouble. But I suspect there's huge differences between the groups. We've gone in the last 50 years fully changed. It was once felt that cataracts were, before telomeres were easily measurable, were a sign of biological aging. And so that people with cataracts did worse. So if you develop, so you might be talking about a subset as well, if that observation were true. So I think it's an important study, but it's still an unsettled question.
Thank you, Dr. Gilbert.
Thank you. I think Gary has his hand up. Go ahead.
Good morning, Amanda. Great job as always. Thank you for your presentation. I'll have to agree with my good colleague Barry on this one. It's a very interesting study, certainly hypothesis generating. It's just really hard to know what to make of it in terms of how these two groups compare in a variety of ways, as well as details such as why did people in the group that didn't get cataract surgeries not get the cataract surgeries? Do the populations differ by health literacy or by other factors that may be associated with the development of the outcome of interest? So I think in that regard, it's very difficult to know exactly what to make out of this study. We don't have visual acuity data if that was a hypothesis. Amanda, of interest, what did the authors suggest might be a rationale for this finding?
I don't think they specifically really commented on that specific question. I think overall, the sense that I was getting reading through the study a few times is actually on the visual acuity. So improvement, it really talked about how they compared with glaucoma surgery, which is not vision acuity saving. It doesn't improve that. So based on that, I'm assuming that that's the rationale overall.
Yeah, I'm just mentioning that because basic principle of research is you have to have a rationale for your hypothesis when you go into something, and then do a series of steps in different studies to try to prove that hypothesis. So I would expect that these authors must have had, maybe I'm being generous, must have had a reason for doing this other than they had a good statistician and a lot of data, and asked someone to run an analysis, and lo and behold, they got an interesting finding. So it is important. People have done funny type of things to bring the point across that show that people who take hot baths are, have a shorter lifespan. And the point they were trying to make is if you study too many things and have a lot of data without clear hypotheses and an approach, it'll lead you to wrong conclusions potentially. So it's a very interesting finding. I just don't know what to make of it. it'd be great to have more data comparing the groups in a variety of factors, and certainly on outcomes from surgery. And Barry raised a great point. Rationale. Why did people choose to have the surgery? May have had implications as well. Great presentation. Thank you.
Thank you very much. And Amanda, I can also ask to clarify, how did they ensure that they were dementia-free at study enrollment? Was that based on codes as well, right?
Yes, and they did a specific introductory enrollment visit where they did a health assessment with a physician as well as cognitive screening test. So I think it's more of a clinical diagnosis at the time of enrollment.
They were also serially, were they not, Amanda, as part of this program?
Sorry?
They were followed serially with assessments as part of the program until
yes, they have biannual visits to pick up and screen for dementia at biannual visits, as well as at the introductory. I think that's what Dr. Gendel was asking. Yeah.
Thank you. And you note, I also noted the absence of reporting on alcohol. Also, relationship status was seemed to be absent.
Yeah.
Very good. Thank you very much. Unless there's one final question, for the sake of time, we will move on. No other hands or questions in the chat bot. Thank you very much for that excellent presentation, Guillaume. Please, our next presenter is Dr. Guillaume Lim Fat, PGY5 resident on the outcomes of comprehensive geriatric assessment in community dwelling older adults. Go ahead, Guillaume.
Hey, thanks for the introduction. I'm Guillaume, and today I'm doing the long presentation at Journal Club on this Cochrane systematic review titled Comprehensive Geriatric Assessment for Community Dwelling High-Risk Frail Older People. This was published in the Cochrane Library of Systematic Reviews in May of 2022, authored by Briggs et al. So usually at this point, I say that I have no conflicts of interest to disclose, but admittedly, I am a geriatrician in training, and the CGA is my intervention of choice. So I'm sure that consciously, subconsciously, that will permeate through any assessment that I do of a CGA-related paper. The objectives today, we'll start by reviewing the evidence for CGA in different settings, because that really frames the findings of this study. I'll summarize the review design and findings. We'll critically appraise the methodology and results. And finally, we'll discuss the study implications for clinical practice. And when I say we, I really mean we have a great room full of geriatricians practicing in different sites, both academic and community. We have lots of trainees at different points in their training. And we have a lot of allied health that work in geriatrics here today. So I would love to hear your thoughts about both this study and how it fits in the evidence for CGAs. And in order to encourage this, I would love to have some audience participation. So at some points, I will prompt you guys to post in the Zoom chat about your opinions. None of them have correct answers. They're just sharing your opinions. And we're going to start off actually with the only question with a correct answer, just to warm you up. Make sure you're paying attention. I want to ask, who is this and how are they relevant to today's presentation? I think this is well known, particularly in this crowd. Oh, I see something in the chat already. Dr. Gendel, which minds? Let me see if I can.
That was my comment.
Oh, I see.
So I'm monitoring the chat. Camilla puts Marjorie Warren, and Victoria Chewin, mother of geriatrics. Oh, there we go. Yeah. You've moved the slide. Thank you.
Yeah, there. Yeah, thanks. Yeah, so definitely a crowd that knows this Marjorie Warren, a British physician who really pioneered specialized geriatric services and the CGA in the early 1920s. And she published these goals for the healthcare of older adults back in the 50s. It's interesting and perhaps not surprising to see that not much has changed. The goals were to prevent disease, to reduce medical disability, to maintain maximum independence, and to teach the patient to adjust themselves to their ability. Which brings us to the modern CGA. So there's a lot of varying definitions of this. This is my interpretation based on a lot of publicly available definitions. I call it a multidisciplinary diagnostic and management process that integrates complexity of medical issues, psychosocial factors, functional status, and values of an older adult in order to develop and deliver a coordinated plan to maximize overall health with aging, administered by providers with specialty training in care of older adults. It's a bit of a long definition, a bit of a mouthful, but there's a lot of important qualifiers there. First and foremost, it does need to be multidisciplinary, and it needs to be diagnostic and management. As Dr. Liu pointed out at an academic half day earlier this week, the CGA is a bit of a misnomer. It's not just an assessment, it's an ongoing management process as well. And so the background evidence for CGA benefit tends to vary quite a bit depending on the different settings, populations, mode of administration, and clinical conditions in which they're studied. So I've listed a few here. I'll start by going over the evidence and summarize the evidence for these different settings, focusing on the highest level of evidence available, that being systematic reviews of RCTs. And so there was this 2017 Cochrane systematic review, and I think a lot of people are familiar with this one, titled Comprehensive CGA for Older Adults Admitted to Hospital. And this looked at nearly 30 randomized trials with some 14,000 participants, showing that CGA for hospitalized patients with a high certainty of evidence increases likelihood that patients will be alive and in their own homes at 3 to 12 months, and decreases likelihood that patients will be admitted to a nursing home at 3 to 12 months, again, with high certainty evidence. There was also little to no difference in mortality and little to no difference in dependence. So this is probably the highest level of evidence we have so far for CGA. There's also another systematic review in the Cochrane Library for surgical patients specifically. This one's titled CGA for Older People Admitted to Surgical Service, and it was published by a Canadian group of surgeons out of Alberta. This came out in 2018, looked at a smaller amount of trials, 8 randomized trials involving a smaller amount of patients, 1,600 or so. And it did show that CGA following post-hip fracture or with elective oncological surgery reduces discharge to an increased level of care with high certainty evidence. They also said in their own words that it probably reduces mortality, but I would draw your attention to the confidence interval with a risk ratio of 0.68, or sorry, a risk ratio of 0.85 and the confidence interval quite wide at 0.68 to 1.05. So it crosses that 1.0 mark, which doesn't really show significance, but came close to it. For the sake of today, I'm going to be very dogmatic and very concrete. If something crosses that 1.0 line, I'll simply say it did not show significance. And there's going to be a lot of confidence intervals that come close, but that's not quite what it shows. They also mentioned that probably leads to reduced length of stay and probably slightly reduces total cost of care, this time with moderate certainty evidence. Next, we have specifically Ortho Geriatrics. So there was a recent systematic review of Ortho Geriatric models of care. This time they included not just RCTs, but observational studies and pre-post analyses as well, which makes this a little bit lower in terms of the level of evidence, but they were able to show reduced length of stay, lower risk of in-hospital mortality, reduced 1-year mortality, and lower risk of delirium. Again, with a pinch of salt, because this is a little bit lower quality evidence compared to the other systematic reviews that looked at RCTs only. In other areas, there's also been good evidence in the geriatric oncology setting. We found with a recent 2018 systematic review that CGA alters oncologic treatment plan in a median of 28% of patients, as it predicts morbidity and mortality, uncovers problems related to cancer care, and it stratifies patients into risk categories to predict tolerance to treatment and chemotoxicity. There's also emerging evidence in the emergency department. The 2017 systematic review showed some significant reductions in admission rates and some variable impact upon readmission rates and inpatient length of stay. Other areas with less evidence, but some emerging evidence include for TAVI patients, where with an observational registry, CGA has been shown to predict death, non-fatal stroke, and hospitalization after TAVI. And so that's been used for prognosticating in terms of TAVI intervention. And in the rehab setting, shout out to our own Dr. Lindy Romanowski, who's shown with her QI and cohort study that addition of CGA and geriatrician co-management improved functional FIM scores, reduced length of stay, and service interruption frequency. So those last ones had a little bit lower level of evidence again, because now we're talking about individual studies and observational data, but certainly some emerging evidence in different areas. So to summarize, greatest certainty of evidence remains in hospitalized patient, that Cochrane systematic review from 2017. There's good evidence for surgical patients, good evidence for orthogeriatric co-management, variable degree of benefits depending on the method of delivery, the population, the setting, and some emerging evidence showing benefit in specific populations and conditions, so oncology, TAVI, ED, etc. Which brings us to outpatients. So what about outpatients? Here's Marjorie Warren again to remind you this is interactive. And I want to ask this time, would you expect CGA to have more, less, or similar demonstrable benefit in outpatients compared to inpatients? Again, I encourage you to type your opinion in the chat to give you some time to do that. I'll share my own, by no means more or less valid than anyone else's here. Without looking at the data, I would have thought maybe they would have less evidence because during inpatient stays, you're at high risk of adverse outcomes, delirium, which then leads to mortality. And so perhaps more evidence would be able to be shown in the inpatient setting. At the same time, you could make an argument that you should have more evidence in the outpatient setting where you're catching frail older adults before they decompensate, even though they're at high risk of doing so. And so being able to prevent those acute decompensations may be able to give you better evidence. Ultimately, I lean towards it showing less evidence in outpatients, or at least I did before reading the study. I'm keen to see what people are saying in the chat, though. Dr. Gandel, if I could bug you one more time to.
So 6 or 7 out of 8 respondents indicated less, and 1 respondent similar. So most were in line with your view, less. About 10 respondents, 9 out of 10 less.
Thank you. Okay, so let's find out together. So this was the newest comprehensive geriatric assessment systematic review in community dwelling high-risk frail older people. Their objective was to determine the effectiveness of CGA for community dwelling frail older adults at risk of poor health outcomes in terms of a few specific outcomes: mortality, nursing home admission, hospital admission, ED visits, adverse events, functional status, quality of life, and resource use. Quite a lot of outcomes. Ultimately, they weren't able to report on all of them, but that's what they set out with. And the comparison being with usual care via systematic review and meta-analysis. And so in PICO format, because we love PICO format, the population was patients 65 years or older, or studies could also be included if they were patients 55 years or older, but a mean age over 70, that satisfied the following criteria. They had to be community dwelling, not acutely unwell, and identified at risk of nursing home admission or defined as frail. And we'll go into how the different studies met that criteria. The intervention was the CGA, and it had to meet the following criteria. It had to be delivered by a healthcare professional in geriatric medicine. I put a star there because in most definitions of the CGA, it's defined as multidisciplinary. For the sake of this study, if it was administered by a single physician trained in geriatric medicine, they still included this study. Their rationale was that if a physician is trained in geriatric medicine, they would involve multiple disciplines as needed, even if it's not explicitly stated in the protocol of that specific study. They also mentioned the CGA had to be used to inform a holistic care plan. It included both single assessments or multiple visits. It had to be delivered in a community setting, of course, but that could be either the patient's home by a home visit, general practice, community-based clinic. The control was usual care. This was usually primary care physicians, family doctors, and community. And the outcomes of interest were the ones I listed. So the protocol was a systematic review and meta-analysis, which we know the Cochrane library does well. Their search methods were such that they started by reviewing a comprehensive list of databases as usual, looked at all trial registers, looked at gray literature, which is outside of traditional commercial academic publishing and distribution channels. They had no language limits, and they reviewed reference lists of pertinent papers, contacted authors, included published and unpublished data to avoid publication bias. So in terms of their selection criteria for studies, they had to be randomized trials looking at CGA versus usual care. The patients needed to be defined as at risk, either by being frail or having some risk factors associated with poor health outcomes. And the studies had to report on the outcomes of interest as we outlined. To select studies, 2 reviewers independently screened titles and abstracts, and then independently screened full texts. They resolved any disagreements through discussion or consulted a 3rd review author, and they listed any studies that initially appeared to meet the inclusion criteria but were later excluded. So they were very transparent at every step. They presented this in a study flow diagram, showing you that they started with some 5,600 studies, and after screening titles and abstracts, ended up with 51 full text articles, which were then screened for eligibility. and finding that 25 did not qualify due to these following reasons, most of which lacking explicit geriatric medicine expertise. That leaves us with a total of 21 studies, 21 randomized studies included for the quantitative synthesis. So these 21 studies included almost 8,000 older participants across 10 countries, 4 continents, ranging from 1996 to 2020. 15 of those studies were randomized at an individual patient level, so individual patients being randomized to usual care or to CGA. 5 of the studies were cluster randomized, so meaning randomized in clusters of patients, such as a specific clinic or a specific hospital site being assigned to CGA, whereas another is randomized to usual care. And 1 study used a stepped wedge cluster design. So I have a really hard time explaining stepped wedge cluster design without using a diagram. So I'd ask you to look at the bottom here. Essentially what it means is that there's different clusters of patients. Again, this can be different clinics, and they all start out as control, so usual care, but at different time points, they switch to the intervention arms. At different time points, they switch to being CGA arms, such that at the end of the study, the total number of time points that all the different clusters within the intervention, the total number within the control, are somewhat equal. A bit confusing. I thought it was interesting to learn about because I hadn't learned about this trial design before. Not too relevant to today's presentation though. And on the list here, I have the list of the full 21 studies that were included for quantitative analysis. And in terms of setting, 12 of the studies looked at CGAs that were delivered in community clinics. 9 of them looked at home-based, so home visit-based CGAs. They defined frailty or at-risk status differently. So 7 of the studies included participants based on an objective assessment of frailty status using validated tools like the Fried frailty phenotype, whereas alternative strategies were used to identify older participants at risk of poor outcomes based on different things in different studies. So 5 studies used requirement for social support. Other studies used recent high level of healthcare utilization, low income status, projected risk of hospital or nursing home admission, multimorbidity, or functional impairment. So now this does introduce some level of heterogeneity to the studies, but I do think it reflects the reality of the patients that we commonly see that are at risk that get referred to our outpatient clinics, and encompasses that it goes beyond physical frailty that puts you at risk status. In terms of data extraction, so 2 reviewers independently extracted data using a standardized data collection form developed by Cochrane, looking at methods, participants, interventions, outcomes, and some special notes. They summarized each individual study, and it's all included in the full report. And they resolved any disagreements in any aspect of the extracted data, either by consensus or involving a third author. They also did a really detailed assessment of risk of bias for each individual study, looking at risk of bias across 8 standardized domains that are listed here. And so the reviewers judged each potential source of bias as high, low, or unclear. And it's not that they excluded studies based on their risk of bias, but they clearly reported the risk and where it came from. And they noted its effect on the certainty of evidence when they presented outcomes. So this is the example of how they presented this risk of bias across all the different studies. These are the 8 domains of where there were possible risks of bias across the different studies. So for example, if you look at the 3rd line here, blinding of participants and personnel, you can see across the board, there was high risk of bias in 100% of the studies, because of course it's hard to blind your participants to whether or not they're getting a CGA. This is the same data presented in a different way. There's the 21 studies across the top here. And you can see for each of them, they looked at all the different domains where there's possible risk of bias and commented on the risk. Now for the outcome analysis, important to note that a different number of trials reported on each different outcome. And so most trials, or the highest number of trials, were the ones reported on death. And there was very few reporting on ED visits on adverse events, ultimately leading them not to be able to comment on those outcomes, even though they first set out to. So here's a summary of results and the big takeaway. They found that CGA probably leads to no difference in risk of death at 12 months. So they use the word probably. Again, I infer because the confidence interval came very close, a risk ratio of 0.88 and a confidence interval of 0.76 to 1.02, so just over 1.0 in showing any kind of evidence for mortality. It also showed no difference in nursing home admissions at 12 months, and that was with high certainty evidence. And they did show the only significant positive finding that it may decrease, excuse me, the risk of unplanned hospital admission at 14 months. Looking at the risk ratio, it's of 0.83 with a confidence interval of 0.7 to 0.99, so just showing significance with low certainty evidence. And we'll explain a little bit why this one was low certainty. For other outcomes, there was less data. So the effect of CGA on ED visits, adverse events, they had to see as uncertain, limited by the number of studies and heterogeneity of the data. There's very low certainty evidence that suggested no evidence on, or no effect on functional status or quality of life. And so they really downplayed those outcomes because of such low certainty evidence. And they could unfortunately not combine the studies that reported on cost into a meta-analysis because of reporting differences and heterogeneity. And as a result, can't comment on cost effectiveness either. So let's look at all the different outcomes. This is the forest plot for death. And you can see they separated the studies that looked at death into those with low risk of bias and those with high risk of bias, and presented the risk ratio confidence intervals for each, as well as the aggregate of all the low risk and high risk studies at the bottom here with a total confidence interval and risk ratio. And so you can see both low risk and bias studies and high risk of bias studies were unable to show significance, although the risk ratio did favor the intervention arm, and the aggregate as well with the confidence interval I mentioned of 0.76 to 1.02. Oh, I should quickly introduce forest plots if those haven't looked at forest plots in a while. These individual horizontal lines represent the confidence intervals from different studies, and the diamonds at the bottom show for the subgroups, and the aggregate at the bottom where the overall statistical analysis is showing significance or not. Next, for the outcome of nursing home admission, so again, separated to low and high risk of bias, with neither of them being able to show significance. And the total, the aggregate, showing a risk ratio of 0.93 and the confidence interval of 0.76 to 1.14. For planned hospital admission, so this was the one where they were able to show significance, the total aggregate confidence or risk ratio was 0.83, and the confidence interval was 0.7 to 0.99, so just showing significance. This is a table they have summarizing all their different outcomes where they were able to comment on the results with the good quality of data. And you can see that the unplanned hospital admissions was the only one where they were able to show a significant difference, with the intervention with a relative risk of 0.83. If you were to plug their illustrative comparative risks, you would find a number needed to treat of 11.2, meaning 11.2 CGAs to prevent one unplanned hospital admission, which is actually pretty good when you think about the NNTs for some of the interventions we consider standard of care. So they concluded that with low certainty evidence that CGA for frail community dwelling older people may reduce the risk of hospital admission. And they noted, unfortunately, evidence related to functional status, quality of life is not robust, further trials needed there. So for the critical appraisal, our usual CEBM framework doesn't apply neatly to meta-analyses. So I had to learn a little bit about how to critically appraise meta-analyses and systematic reviews. And these are the questions that I came up with. So going through them one by one. Was the search for relevant primary risk studies exhaustive? While they had a very comprehensive list of databases and clinical trial registry included, they included gray literature, published and unpublished data. There was no language limits, and they had detailed search strategies reported in the full study. So they were very transparent. So I have to say, yes, it was exhaustive. Were the criteria used to select studies for inclusion appropriate? I think they had appropriate population limits with regards to age, frailty, or at-risk status. They included both clinic CGAs and home-based CGAs, which I think is appropriate. They included randomized trials, which were either individual randomized, cluster randomized, or use step wedge cluster design. And then they had 2 reviewers independently screen the studies, resolving any disagreements with a 3rd reviewer, so reducing risk of bias that way. And they recorded and published reasons for exclusion of any ineligible studies, which again is very transparent. So I have to say, yes, this was appropriate. Next, was the methodological quality of studies appropriately assessed? Again, they had independent reviewers appraise the individual studies, identify risk of bias across all those standardized domains of possible bias. They included all study characteristics and appraisals and reported in the systematic review. And for all studies included in the meta-analysis, they were separated into low and high risk of bias subgroups, and they did a test of subgroup differences to see if there was significance between those two groups. So just to show again, they did a very thorough job of looking at different domains of bias across all the different studies. So I have to say, yes, it was appropriately assessed. Next, was there clinical heterogeneity among studies combined for meta-analysis? So clinical heterogeneity referring to variability in the different studies that were included. So admittedly, yes, there was some variability in the study design. There was different definition used for either frailty or at-risk status. There were differences in the delivery of the CGA, either home-based or clinic-based. And there is going to be inherent variability in what constitutes a CGA at any given site. They included both single assessments and multiple visits. And we mentioned CGA being a misnomer. It's supposed to be a assessment and management plan. And they also included non-multidisciplinary assessments by physician only, though I agree to some degree to their rationale for that. So overall, I have to admit some clinical heterogeneity among the studies they combined for meta-analysis. Next was their statistical heterogeneity. We'll talk a bit about that, what that means among studies combined for meta-analysis, but that's dependent on the specific analysis. So we have to look at the separate forest plots individually, looking at those different outcomes. So let's look at the one for death. So statistical heterogeneity refers to, in very simple terms, whether the results of each individual study tend to line up with one another. And so the eyeball test for this tends to be, if you can look at a forest plot and you look at the confidence intervals of all the different studies, can you draw a straight vertical line that crosses all the confidence intervals of the different studies? And for this example, it's actually quite easy because at the 1.0 mark, there's a nice vertical line that crosses all the confidence intervals of those studies. Now, that's just an eyeball test. There's also quantifiable ways of doing statistical analysis and looking for heterogeneity, statistical heterogeneity, and it's reported down here, chi-squared and I-squared. Not to go into too much detail, but the I-squared is a quantifiable way of looking at heterogeneity. For this case, it's 0%, which indicates minimal or no heterogeneity. For the outcome of nursing home admission, this time again, trying the eyeball test together, let's see if you can draw a vertical line that crosses all these confidence intervals. You just can't. You almost can, but you can't. And so that suggests some level of heterogeneity, and that's reflected in the I-squared value of 18% here, suggesting low heterogeneity. Looking at unplanned hospital admissions, this time eyeball test again. Can you draw a vertical line that crosses all these confidence intervals? You can't, and it's more clear here that you can't. And so with the I-squared also, the I-squared value here also shows that higher level of heterogeneity at 63%, which suggests moderate heterogeneity. And that's partially why the outcome of unplanned hospital admissions is reported with lower certainty of evidence. Finally, functional status. This is the first time I'm showing this particular forest plot because they downplay these results because of the degree of heterogeneity. And you can look at it, it's quite clear, eyeball test. You can't draw a vertical line that crosses all the confidence intervals. There does seem to be a lot of heterogeneity between the different studies. Their I-squared value here is 75%, indicating high heterogeneity. So was there statistical heterogeneity among studies? Yes, for some outcomes there was, but they were transparent about the way that there was heterogeneity, and they used that to share with the degree or the certainty of evidence with which they're presenting different outcomes. Lastly, are the assessments of the studies reproducible? Well, there's explicit criteria documented at each step. Exact search strategies are provided, multiple independent reviewers, lesser risk of bias there. So overall, I do think that yes, the assessments were reproducible. So overall, my thoughts, I do think it's an overall low risk of bias. They're very transparent. The degree of certainty of evidence provided with every claim, the reported when evidence was inadequate to comment on a specific outcome due to lack of evidence or heterogeneity. One more time, this is the summary of all the different findings. I'm happy to go back to this when we go to the discussion. I should mention some other studies or systematic reviews that looked at similar things. The closest thing to this one was a systematic review in 2004 that looked at outpatient CGA as well, but specifically for mortality only. And they showed that there was no effects on mortality compared to usual care in frail older adults after an outpatient CGA. I included a second one, mostly because it's recent out of BMC Geriatrics this year. That was a systematic integrative review, meaning included not just RCTs, but also pre-post studies without controls, case control, qualitative methods as well and mixed methods. And the CGA is actually just over 50% were nurse-led rather than physician-led. And it showed heterogeneous results with low certainty, weak evidence of improved functional status, frailty, fall outcomes, mental health outcomes, self-rated health, and quality of life, with a bit of a grain of salt because of the difference in methodology compared to the other systematic reviews. So again, this is the summary of results, and based on my assessment, my critical appraisal, I tend to accept these results as correct, that there was no difference in the risk of death at 12 months, no difference in nursing home admissions at 12 months, and may decrease the risk of unplanned admissions at 14 months with a number needed to treat of about 11 CGAs. So Marjorie Warren, again, to remind us that this is interactive, I want to ask this time, and this is really what I was hoping to get out of this, how do you feel about the results of this study? Here are some different options. A, do you feel validated by the demonstrable risk of CGA in outpatients? Number needed to treat of 11 is pretty good, and to prevent an unplanned hospital admission is a very good outcome. Do you feel B, disappointed that greater benefit could not be shown? Do you feel C, indifferent because CGA benefit cannot be captured in systematic review and patient-centered medicine is its own reward, as corny as that sounds? Or D, is there some other way that you feel about the study that you'd like to share? So I'd invite you to share your thoughts. It could be a mixture of any of the above. I'll share my own. Again, no more valid than anyone else's here. I feel a mix of A, B, and C. So I do feel validated that there's some demonstrable benefit and some really relevant outcomes, or the particular outcome. I do feel disappointed, though, that greater benefit could not be shown, especially when I look at those confidence intervals. I wonder if there was more studies, could we show mortality benefit, even though mortality isn't necessarily where I think we make the most impact. At the same time, I feel a bit of C, indifference, in that CGA benefit cannot be captured in a systematic review. And I don't think this systematic review, despite how much it informs our decisions, changes my clinical practice. I will continue to practice patient-centered medicine. And to kind of elaborate on that a little bit further, we'll go to the chat in a bit. I want to propose the idea of SGS, or Specialized Geriatric Services, or CGAs, as not just a patient intervention, but as a healthcare intervention. And if you think of the quadruple aim, which is this compass that's widely accepted for improvement of healthcare, it looks at 4 different things. And patient outcomes, being very important, is only one of those things. It also looks at lower cost of care, improve patient experience, and improve provider experience. If I think about this particular study, it was able to show some modestly improved patient outcomes. It tried to look at lower cost of care, but didn't have enough data to do so. It didn't look at patient experience. I know some other studies have, but I think it would be interesting to include that whenever we think about the value of a CGA. And less studies look at provider experience. Now, I can only speak for myself, N of 1, but I do think our studies improve the provider experience of those, certainly those who refer to us, and I would even say it improves our own experience. I can't think of practicing medicine without integrating medical issues, psychosocial factors, functional status, or values of an older adult. That would not be fulfilling or rewarding medicine for me. And so I can say that CGA improves my provider experience, and I suspect the provider experience of a lot of people in this room today. Okay, so now I'll look at the discussion and take up any questions. This is not Marjorie Warren, but this is someone who's equally, if not more important for geriatrics for me, who's my late grandmother. I'll let you guess who that is with her. This is an older picture. So thanks. I'll go to questions and discussion now.
Thank you very much, Guillaume, for the excellent presentation. Very thought-provoking. The interaction and all the educational points made were fabulous. Most of the chat reaffirms what you mentioned in the discussion. Gary has his hand up and also selected D. So go ahead, Gary, for the first comment.
Thank you very much, Guy. Very elegantly presented, and certainly you and Amanda did set the very high bar, not only for your fellow residents, but for your faculty as well. Nicely done. So I guess, Guy, I'd like to get to the crux of the matter, which to me are the perennial problem with studies in geriatric medicine that get waylaid by the traditional what I might call almost administrative or standard outcome measures, because that's what everyone else does in their studies, and wonder very specifically whether you think when you're looking at a frail older population that we're applying a CGA, are outcomes such as mortality or even nursing home, which, as we know, in certain instances, a good outcome would be that we got one of our patients into a nursing home because that's the best environment for them to meet their health and social needs. So do you think that the outcomes are appropriate before we start shedding a tear that we haven't proven effectiveness with respect to them?
Oh, I completely agree. The usual outcomes that are used for studies to comment on efficacy of interventions do not apply to geriatrics the same way, particularly because we take the values of the patient into account. And not to say that other disciplines don't, but with such a focus on it, the values of the patient do not necessarily align with what healthcare as a whole considers good outcomes. I think it's still important to look at these outcomes because this is how you unfortunately have to convince stakeholders and people who control budgets about interventions. But at the end of the day, I wouldn't let any comment on mortality or nursing home admission change how I practice CGAs.
Yeah, I mean, I'd even push that a bit stronger. I think it would be erroneous for us to allow an outcome that shows that we didn't reduce nursing home outcomes to be a factor at all as to whether a service like a comprehensive geriatric assessment in the community is worthwhile or not. So I think it's up to us, and particularly you, our next generation, to carry the flag to make sure that when we're assessing outcomes, and Guy, I couldn't agree with you more, the quadruple aim is a great place to look because there's 4 separate categories and looking for outcomes of importance within them, I think it is a great way to think about it. But I certainly think if we're stuck measuring mortality in nursing home admissions 15 years from now, somehow we've failed our specialty by allowing that focus to continue, because those are certainly not the outcomes that are relevant. I mean, how many patients do we deal with in our clinics and outreach teams that are palliative? I mean, is mortality a meaningful outcome for those people? Of course not. Thank you very much. Great job.
Great. Can I ask a question too to Guillaume, Gary? A lot of great comments in the chat box, but some of the comments are, do we really need 21 RCTs and why are we measuring? And I agree with that. One question in terms of the power with a negative result. And so the sample sizes, the greatest sample size I think was 2,000 for the death as the outcome. And any comment on whether or not the negative result was this lack of power? Is that something to consider in the individual RCTs or the meta-analysis?
I would suggest, Dov, that we shouldn't get caught in the trap. If we only had another 200 patients, we would have pushed it past the finish line. I think what's lacking in power are the outcomes. We'll be holding ourselves back forever if we tie ourselves to outcomes that we don't think are particularly appropriate to the patient populations that we serve. I think the most important question with respect to confidence intervals for all of us to think about is how narrow they are in general. When you have very wide confidence intervals, that would suggest that your power is likely considerably too small. If you just nudge past 1, but the confidence intervals are relatively small, it probably means that this is the result, right? So you can't keep adding people to try to push you across the finish line. So I think really the size of the confidence interval should be one of the most telling things for you as the reader as to whether, we've talked about this before, is it a true negative result versus an uncertain negative result? So if the confidence intervals are very wide and they cross 1, it's likely an indeterminate result. Whereas if they're very narrow, even if they're close, but they don't, that's a result that's probably more meaningful to us.
Thank you for clarifying. It's the top of the hour. I want to thank both of our co-chief residents for fantastic kickoff presentations to the year. Thank you everyone for joining. Special recognition to the SOAR, Barb put in the chat box, the SOAR experienced students who are with us today. And also we didn't have a chance to recognize Dr. Terumi Izukawa in person on winning the Barry J. Gold List Teacher of the Year Award. And so I'll take a moment if Terumi is there to congratulate Terumi on her award, which we were not able to do in person. Congratulations, Terumi.
Thank you everyone, and thanks to the residents. I'm really honored, and it's a special honor to get an award named after Barry, who was one of the people who inspired me to go into geriatrics. So, thank you.
Great. I'm glad we could have that moment, and a lot of congratulations in the chat. Final reminder, the evaluation link was sent about 10 or 12 minutes ago. Please complete the evaluations and enjoy